Okay, so today we're going to talk about SPECT imaging and some of the important things that we do with it and how we acquire images. And so let's start off with this. First of all, let's talk about some of the basic photons that we kind of image or don't image. So we have alpha particles, which are basically helium nuclei. We have beta particles, which are electrons. We have gamma rays. And all of these things have differential effects in terms of relative biological effects and overall effects on the body. Obviously, we look at different kinds of parameters such as equivalent radiation dose, and it turns out that that's mostly based on the type of radiation emission you have. And so if you look at alpha particles, they're actually the most dangerous. They give like, they have a factor of 20 in terms of the number of ionizations per particle. So they can be very devastating, even though they can be basically stopped by a piece of tissue paper. And then we also have gamma rays and beta particles, which beta particles can be stopped by simply a piece of paper, not even a tissue paper, but just a piece of paper. And really, the only thing that we really image is gamma rays, because obviously, if we inject a radio tracer, it wouldn't be very effective to give alpha or beta particles to get an image if you're talking about emissions. So we image gamma radiation, but just keep in mind that alpha radiation is the most devastating of all. And in fact, you know, it used to be called the, I guess it still is, the assassin's choice. There was a Russian spy several years ago that was given as tiny as 1 grain of salt of polonium, and which is an alpha emitter. And several weeks later, he died a horrible death from that due to alpha emissions in the body. So just something to think about. Beta and gamma rays are actually less devastating because they only have a factor of 1 as compared to alpha particles, which have a factor of 20. And again, we don't image alpha or beta anyway. We concentrate on gamma. All right, so let's go move on. So of those things that we image, what we really base everything on is photoelectric effect in terms of both in tissue and in crystals, having absorption of an X-ray emission to create an image. And the other thing that happens in tissue and in crystals is what we call Compton scattering. So you might not have total absorption of an electron or an X-ray particle, and therefore it kind of bounces around and loses energy with each little individual bounce, as we'll talk about. And then we have positron emissions, which are very standard. They're all at 511 keV and due to annihilation of positrons with electrons. And another thing we need to remember is that when we talk about positron emitting agents, that a lot of what we do is based also on the spatial resolution of the agent. And so if you take something like rubidium-82, it's got a KeV of 3,350. Okay, well, that's pretty darn high considering that in other modalities like technetium, it's 140 keV. But it's a very short acting half-life of 75 seconds, so it doesn't cause a lot of radiation damage. But because of that high keV, it goes quite a long distance, like 2.6 millimeters before it annihilates. And so the spatial resolution of rubidium is relatively low. And then you take something like F18, which only is 630 keV. And so it travels less before it gets annihilated in tissue. So if you look at a point source, you can see that really F18 has the best spatial resolution, and rubidium has the worst spatial resolution because it annihilates so far out from where it originates because of its high energy. Okay. There are several things we don't image. Like I already said, we don't image alpha and beta particles, but they do have different interactions. They can cause excitation around nuclei. They can actually go in alpha and beta particles and kick out a lower level electron and cause a drop of the outer level electron into the shell of the lower level electron and lead to a characteristic X-ray. And we also have this thing called Bremsstrahlung, which I have always a hard time pronouncing, which is called breaking X-rays, where you have an electron going around the nucleus, and as it slows down, it gives off energy because there's always got to be, you know, conservation of mass and energy. So as it slows down, it gives off energy. And in fact, in CT, what we typically do is we look at ionization, which is characteristic X-rays, when electrons hit tungsten rings and give off characteristic X-rays. That's how we're getting our pictures. And we also have something called Bremsstrahlung, which is very common in CT, that allows us to have X-rays. So unlike nuclear cardiology, where we always look for gamma radiation and we look for photoelectric effect in terms of photoelectrons being absorbed, in CT it's just the opposite. Actually, we use electrons, etc., to lead to ionization, characteristic X-rays, and this Bremsstrahlung, which allows us to image patients. Okay, photoelectric effect typically happens in tissue, which we really don't want it to happen in, and also when it hits the sodium iodide crystal, which is our typical crystal in SPECT imaging. And what happens is that as this thing hits, it is absorbed and gives off a little scintillation, which is called light. And that light is picked up by photomultiplier tubes, and it's called a photomultiplier tube because it basically multiplies or amplifies the scintillation to a great extent, where it's then converted into electrical impulse and identified. The other kind of factors we have with SPECT imaging is called Compton scattering, and this is when incident photon comes in and it hits tissue, and instead of being completely absorbed, it bounces and it scatters another direction, and it can bounce and scatter in multiple directions, and that leads to terrible reduction in spatial resolution, because if it originates here and it's finally absorbed here, you can see that's going to really degrade your image quality. So Compton scattering, which is extremely common in tissue, is a real problem with SPECT imaging. The other thing I want to mention is that the greater the angle of deflection, the greater the energy loss. But one important issue is that low energy photons actually lose less energy with any degree of angulation. So to give you an example of that, with thallium, which is only 72 keV, you'd have to have a 72 degree angulation to go outside the energy window of accepting that as a real photon, or accurate photon. With technetium, it's 54 degrees, but look at F18, it's only 27 degrees. So once it goes past 27 degrees, it says, gone, we're not accepting you. But look at all the photons that you're going to accept with thallium technetium at great angulations, which again degrades the spatial resolution. So Compton scattering is extremely important. It happens in both SPECT imaging and PET imaging. But again, because of the way F18 agents are such high energy with 511 kV, the amount of scatter is less. And again, you can see this in terms of incident photon and how it can deflect in many, many different ways. And where it finally ends up is where it's then hopefully gets outside the body, or maybe it doesn't, maybe that would be better, because it just leads to a degradation in spatial resolution. So if you look at nuclear cardiology and CT, they're actually quite similar in many respects. Single photon emission computed tomography uses radio tracers anywhere from 72, which is thallium, kV, up to 140 kV. PET imaging is always 511 kV, although remember the energies of every different PET radio tracer is different. Some are very high energy like rubidium, and some are very low energy like F18. And CT, generally, we use kV in the range of 70 to 140. And when we generate electromagnetic radiation in CT, remember that KVP or the KEV is really equal to what you would say with a radio tracer, like 140 kV technetium. It's what we use to get tissue penetration. And the photon flux, or the number of photons that actually are going into a system, really determine the image quality. Right? So I always think about it in this way. KEV is like the train, and MEV, millivolts, milliamperes, or photon flux is really like the cars behind it. You're carrying all this stuff. So you're really delivering all of this stuff, these photons and these milliamperes via the KV, which is the train locomotive, and that's how we make images. And so you can see here in SPECT, for instance, or any kind. This is just a liver example. You have a photon coming off. In SPECT, we use lead collimators. Generally speaking, we'll talk more about that. If the photon is direct off the body and it can get through the hole of the collimator, it's hit by the crystal. The crystal leads to a scintillation, which is amplified by a photomultiplier tube, and then you get your electronics telling where all of these things are occurring, and you get a picture. And so in a radio tracer, we have emission, basically, right? We have technetium, generally speaking, which we use is 140 kV. We have photon flux, which is based on the amount of millicuries we give a patient, as well as the time that we image a patient, okay? So if we image a patient for 10 minutes, we don't need to give as many millicuries, but if we image a patient for only 5 minutes, then we have to double the dose of millicuries to get the same amount of photon flux to make a picture, right? That makes sense. And obviously, what we really want to do is minimize attenuation of photons, okay? Because we want to have enough photons to make a picture. With CT, it's the same thing. I mean, you have 140, you have 120, 130 kV, and you set your milliamps at a certain level in order to develop a picture. And so, unlike the emission studies you get with SPECT, CT is a transmission scan, not an emission scan, but a transmission scan through the body. And again, you get the same. The images are created using the same kind of principles that we have in SPECT imaging. Now let's talk a little bit about photon interactions in matter, because we have lead, and we have the sodium iodine crystal, which we like to have the photons interact with, and we have soft tissue. And you can see that if you look at 511 kV, most of what you see is actually Compton scattering. Only photoelectric effects occurs at very dense materials like lead, okay? If you look at soft tissue in terms of technetium or thallium in blue, you can see that most of what you get with thallium and technetium is actually Compton scattering. And that's usually in tissue with also photoelectric effect in the crystal, because you can see that the majority of photons at that particular density of sodium iodide crystal is going to be photoelectric effect with thallium at technetium. But in soft tissue, most of what you're going to get is Compton scattering. Also remember that photon attenuation is due to many different things. It depends on the photon energy. Like we already said, 511 kV is not going to attenuate as much as something like thallium, which is much lower energy. It's going to also depend on the material density, okay, how thick the material is, and it's also going to depend on the actual thickness, not just the density, but the thickness of the material that you're doing. Okay. Let's talk a little bit about collimators. Collimators are very important because they help direct the proper photons to the gamma camera sodium iodide crystal. And so you can see here that photons that go through the collimator are, generally speaking, parallel to what's being emitted from the body, okay? And those that are not parallel to those emitted to the body are absorbed by the lead septi of the collimators. So as it turns out, and this is a generalized statement, it depends again on what kind of collimator you're using, but at best, only 1% of the photons that are emitted from the patient actually are registered by the sodium iodide crystal. Well, that's pretty abysmal. I mean, 99% of all photons never get registered by the sodium iodide crystal, which is one of the reasons why, we have to give the millicurie doses we give in order to generate a proper image. Okay, let's talk a little bit about image resolution. So image resolution is based on what we call the full width half maximum. And so if you look at this particular graph, you can see it looks like it's just a Gaussian distribution. And half of that is called the half peak, which is the half width full maximum. And so if you have on the left one, let's say, dot that's imaged, and on the right you have one dot that's imaged, the only way you're going to be able to discriminate between those dots is that if the dots are separated by greater than the full width half maximum of the objects, okay? So you can see that yellow line, if those were two separate dots, that yellow line would allow is the full width half maximum. So anything beyond the yellow line, two distinct points would be able to be identified. Does that make sense? Okay. Now, what if this happens? Here you have another point spread function, and you've got the full width half maximum, and now you have another point. So you got 2 points. And these 2 points are separated by less than the full width half maximum. So you would not be able to discriminate these 2 points in a study. They just look like one big blob rather than 2 distinct points because they exceed the width of the full width half maximum, okay? All right. Let's talk a little bit about how then collimators work. So we have collimator resolution, which is really determined by the diameter and length of the collimator holes and the distance from the face of the collimator. And we have the collimator sensitivity, which is really an indicator of how many photons can be accepted or go through the collimator to hit the sodium iodide crystal. And so as you might suspect, based on what I've already told you, if you increase the diameter of the hole between the septi, more photons are going to get through, okay? And so the sensitivity is going to increase, and sensitivity being the number of counts that actually hit the crystal, right? However, you sacrifice sensitivity for resolution, because if a lot of those photons that are going to get through that big hole are going to be scattered photons from all different parts of the body that we shouldn't or wouldn't want to even image, okay? So there's always this balance between resolution and sensitivity, the number of counts that you can actually acquire. Conversely, if you increase hole length, okay, so if the septi become longer, it will be tougher for those Compton scattered photons to get through. And so you will decrease sensitivity because less photons get through, but you'll markedly improve resolution. So when you think about the best kind of collimators, if you really want a high resolution collimator, it should have very small holes, and it should have very long septi. And that will give you the best spatial resolution. But you'll have to acquire for a long, long time to be able to get enough counts to make an image, okay? So generally speaking, we have to trade off one for the other in order to get good images. And you can see here that resolution, this is resolution versus sensitivity, and you can see this is this is an extremely high resolution collimator, where the sensitivity is very low, but the spatial resolution is very good. And then as you go up into a high resolution, the sensitivity gets better, but the resolution gets worse. Which is typically what we use in SPECT is high resolution. So you can see it's like 7.2 millimeters, which is not that good. If you go to these more sensitive collimators, like these high sensitivity collimators, you can see that you lose a heck of a lot of resolution, right? You get a lot of counts, a lot of sensitivity, but you lose a heck of a lot of resolution. So that's why, generally speaking, we compromise with SPECT, and we use high resolution collimation to try to get enough counts, but also to optimize or at least have reasonable spatial resolution. What's also important to recognize is the distance from the collimator where the point source is in terms of what happens to the full width half maximum. So on the top you can see the point source, and you can see that the full width half maximum is pretty narrow there. But if you move the point source further away, look what happens to the full width half maximum and that point point spread function. You can see it widens out tremendously. Okay, and so it's very important when we do SPECT imaging that we get the patient as close to the camera as possible to maximize our spatial resolution, okay? And you can also see that if you go from, a more sensitive collimator to a high resolution collimator, even though the point source may be further out, you still, look what happens to the point spread function at the bottom. I mean, it's still relatively narrow. So again, we can offset some of this distance issue and et cetera in terms of resolution by having better collimation. But again, you're sacrificing counts when you do that. All right. So again, for all collimation, resolution degrades as the object is moved farther away from the collimator source. So when we image patients, it's absolutely imperative that we get them very close. In fact, just think about it. You have better resolution actually of the anterolateral wall of the heart than you do the posterior wall of the heart, because the posterior wall of the heart, irrespective, is going to be deeper and further away from the collimator than the anterior wall of the heart. So you have differential loss of resolution just based on the patient itself, irrespective of where the camera head is actually placed on the chest. And you can see that here in terms of spatial resolution, that as you go further, as that camera collimator goes further away from the body, the point spread function becomes extremely wide and your spatial resolution degrades tremendously. Okay. So we talked a little bit about collimators. Let's talk a little bit about the actual detectors and such. So the sodium iodide crystals are pretty mainstay, although nowadays, still not being used very much in general, offices, CZT has become now the gold standard in SPECT imaging, and we'll go into why that is in a minute. So you have scintillation materials, you have light detectors, which are photomultiplier tubes. Now, we already talked a little bit about the photomultiplier tubes, because when the photon hits a sodium iodide crystal, it causes a scintillation, and that's amplified by the photomultiplier tube. But it turns out with CZT, you don't need photomultiplier tubes. They're irrelevant, because the actual scintillation in a CZT crystal leads to actually an electrical current directly. So you don't need to multiply or amplify the light to be able to create a current. And then we have the voltage discriminator, which is very important in terms of looking at the energy that we're imaging, and the display. So I'm not going to go through this, that's kind of moot, but here's the voltage, here's the the voltage discriminator. So remember, you have all these photons that are coming in, and the ones in yellow are actually the ones that you want to keep because they're actually the ones within our energy range. So take that yellow bar, that's like maybe 140 kV, and those photons are within that 140 kV. And so the pulse height analyzer recognizes that those photons are good photons and can keep them. The remaining photons are probably scattered photons, Compton scattered photons, etc. So if you look on the right-hand side of the screen, again, the energy window is that bar, and you can see that some photons lie within the energy window and some do not, and the ones that lie within the energy window of the ones that are collected from the sodium iodide crystal are the ones we're going to keep. And so we usually put like a 20% window across that 140 kV to be able to identify which photons are good and which photons are bad. And all the other photons toward the end of the spectrum are usually just Compton scattered. And in fact, we get a lot of different Compton scatters. So we have back scattered photons. We can have Compton 1 scattered photons where you only have one scatter, or you can have multiple scattered photons that come into the sodium iodide crystal. And what we can do is we can, with the pulse height analyzer, we can discriminate which one of those actually are good photons and which ones are bad, and hopefully therefore eliminate a lot of the scattered photons in terms of what we do. And so when you look at a typical energy spectrum, this is what you see. You see the photo peak, which is really what we like, which sits within our window of accepted photons, although some of those Compton scattered photons will also get in. And we have all those other lower energy photons, which are, generally speaking, second and third and fourth order Compton scattered photons, which have lost so much energy that they're quickly eliminated. Okay. Now, recently, there's been nice innovations in terms of what kind of SPECT cameras we have. The objectives of all of these new CZT and cesium iodide crystal detectors is first of all to reduce imaging time, because that leads to less patient motion, etc. To improve sensitivity, to get more counts per second, so we get better imaging. To improve energy discrimination, so that we accept less of the bad photons, and thereby improve spatial resolution, and also to reduce radiation exposure. And like I said, there are several different camera systems out there. There's a DigiRad system. There's a spectrum dynamic system out there, which uses pixelated CZT arrays. And there's the GE MyoSpect camera. All of these newer cameras, incidentally, are also equipped with CT for CT attenuation correction. And again, remember with CT, with CZT, we directly produce an electrical impulse from the scintillation, from the gamma, from the crystal interaction, rather than having to go through photomultiplier tubes and all of these other arrays. And this is just a typical array of what you see. All of these systems now are fixed gantries. As you know, we have still a lot of these rotating gamma cameras that go over 180 degrees. All of the CZT cameras are now fixed arrays over about 180, 120, 180 degrees. So you lose a lot of the, we lose some specific artifacts by having fixed gantries. But it also allows us to acquire more counts within a given time period. And so analog imaging, which is typically with photomultiplier tubes using sodium iodide crystals, you can see on the left, and digital, which using CZT technology, is on the right. And you can see that, I hope you can see that the images on the right are crisper and cleaner and have better spatial resolution than the images on the left. And that's what we're hoping for when we do this. The other thing that's nice about CZT cameras is because they have such high sensitivity in terms of being able to acquire counts at such a high rate, there's actually the opportunity, as in PET, to do flow measurements, to do absolute flow measurements at rest and during stress. And so a lot of what we do with PET now in terms of looking at myocardial flow reserve can also be done. And there are some nice papers showing pretty good results using CZT technology to do myocardial blood flow measurements. So CZT has a fairly good density. It's got a very, very good energy resolution of less than 5%. And like I said, these usually consist of little individual wafers with lead septi in between that are extremely thin, which by that measure improves our ability, our sensitivity in terms of acquiring counts and all the rest, but it does not grade the specificity, or I should say the resolution, because of the size of each one of those little wafers, and also because of the energy resolution, which is extremely good. And so if you look at sodium iodide and you look at CZT, this is a comparison of that pulse analyzer width. You can see that CZT only has about, its energy resolution is down to about 4.5%, whereas sodium iodide is about 10%. That's like, quite a big difference in terms of being able to discriminate proper photons from bad photons. All right, let's talk a little bit about image reconstruction. All image reconstruction uses filtered back projection, which is why we do arrays. And this is not only true in SPECT and PET imaging, this is also true in CT. I mean, everything is filtered back projection. So we get multiple views, and we put together a picture, and usually we just need about 180 degrees of coverage, which is one of the reasons why in CT, for instance, we can get such good temporal resolution, because we only use a half spin of the camera. We don't need the full spin. So if you have a gantry that moves around rather quickly, you can get pretty good temporal resolution just based on using the 180 degrees rather than the 360 degrees. And so this is just an example. If you look at the image on the upper left, you can see this is one view, one angulation. Now on the upper right, we have two views, and there's a little bit more interaction. Now we go to the lower left, and now we have multiple different angulations, and finally an 8th view, and now you can see we see an image where all of those lines intersect, okay? And that's what basically filtered back projection does. It puts all of these different angulations together, and where they all intersect is where you're going to get a maximum intensity, and it's going to form an image. Okay, so this is the basics of all imaging. You have to have filtered back projection to get a three-dimensional image and be able to identify it. Let's talk a little bit about filtering. So the question is, how much do you filter? Okay, high frequencies are something we always like to look for. They're like edges. If you come to an edge and you fall off the edge, that's a high frequency. Low frequencies are like a flat surface, okay? No change over time. And you can look at these images and just get a feeling for how frequencies might affect an image. So here's a frequency of a little mountain. You can see the original image on the left. You can see removing only the very high frequencies. You can still say, it's pretty good. It's not too bad. Now we go and we remove the high to medium frequencies in the bottom left. You can say, well, I can still see there's a mountain, but can't see a lot of detail. And then you remove all except the low frequencies, and now it's a blur, a total blur, okay? Well, in SPECT imaging, if you remove all the frequencies, all you'll see is a blob. You wouldn't even be able to distinguish a heart. And if you take away all of the low and medium frequencies and you just have high frequencies, you'll have a very granulated, noisy image. So again, we have to kind of balance how much filtering we were going to do in terms of being able to look at an image. And the other thing I want to also mention, because you all who image here look at computers all day long, but you can have the best intrinsic spatial resolution okay, on your CT system or your SPECT system or your PET system, but if your computer system is not a high resolution system, it will do you very little good, okay? Because the image resolution is based on what the pixel size is on your computer, okay? So it's very important when we have imaging that we use the best computer screens with the best image resolution with the highest number of pixels to be able to really read a study properly. Okay, so again, when we talk about filters, always remember that filters always remove information. And the optimal filtering will also, I mean, when we first started SPECT back in 1985, I remember we got our first SPECT system in 1985, we had to fiddle around with all different types of cut points and everything to be able to determine what would be the best filter in terms of detecting coronary artery disease. Those are pretty exciting times because before that we just had basically planar imaging, which is like 3 views, and it was that was something else. And but with SPECT, you know, we just had to kind of make decisions about what cut points we were going to use in order to make sure we could identify a perfusion defect, and yet at the same time, you know, not make it so noisy that we'd overcall things. So it was really a balancing act. Okay, so this is looking at what we were talking about cut points, because if you look on the left, you can see this is taking away most of the high filters. And you can see it's a very noisy image. And as you go along there, we're actually you know, changing the frequencies in terms of getting rid of the high frequencies, maybe some of the medium frequencies, until we have just the low frequencies. And you can see how blurred the image gets toward the right. Okay, so again, it's a matter of gradually adjusting you know, frequencies to your liking to be able to better you know, interpret a study. And I can tell you, you know, one of the issues, especially in low count studies, is sometimes I'll actually change the filtering to make it more blurry. Because remember, with low counts, you have a lot of noise, and so you have to blur out the noise in terms of being able to see an image. So sometimes we have to change the frequencies just to be able to potentially interpret a study. But we like to stick pretty much with the same filter all the time. Okay, so that brings me to another issue about counts and why counts or sensitivity is so important. Because noise is based on what your count density is. So for instance, if you had an average count of 100 counts per pixel, you would have 10% noise, which is really pretty unacceptable. But if you had 10,000 counts per pixel, you would actually go down to 1% noise, okay? So it just goes to show you that, you know, images are made by how many counts you have. Images are made by what your MA flux is, okay, in CT. And if you don't have enough MA, and if you don't have enough counts, you're going to have very, very noisy images, which are going to limit your ability to interpret the studies. So it's extremely important that we you know, apply the proper time to acquire the proper number of images. Now, one thing we can do nowadays, which we didn't have before, is we can do iterative reconstruction. And it's been shown very nicely that, particularly in SPECT imaging, that you can reduce the count density by about 30% and still get equal image. Well, the images will look pretty similar if you apply iterative reconstruction over just regular reconstruction. So iterative reconstruction does help in terms of especially low count studies. We do that in CT a lot. My goodness, we do, Admire 3 and Admire 4 all the time when we have low count studies, particularly in, obese patients where you get a very poor MA flux. So iterative reconstruction can help, but still it's much better to acquire as many counts as you can rather than trying to use software techniques to improve your image quality. Okay, so what does higher KV do? It basically allows you to get, it allows you to get photons through tissue, and it allows you to have more of a photoelectric effect in the crystal and less Compton scattering. Okay, and so in SPECT, that's why we basically went away from 72 keV thallium. Even though it had a better extraction fraction and had, redistribution at 4 hours to look for ischemia and all of this, we basically have, resolved to technesium in SPECT imaging because of the higher KV and therefore less photon and therefore greater photon acceptance by the sodium iodide crystal and less Compton scattering than what we see with, for instance, thallium. All right, so there are other issues besides what we've talked about so far in terms of the gamma cameras. There's also this thing called gamma camera uniformity. There's spatial resolution and linearity, and there's the center of rotation. Uniformity refers to the ability of a gamma camera to display all the different information uniformly across the face of the camera, across the face of the sodium iodide crystal. If you have non-uniformities, it can create artifacts and it can lead to a lot of misinterpretation. And what we generally speaking do is we do several different QC type procedures on images. Integral uniformity and differential uniformity. Integral uniformity looks at the entire head of the camera, of the surface of the crystal. Differential uniformity looks at specific lines along horizontal and vertical lines within a given space. So integral uniformity is something we do all the time. It's imperative that we make sure that that these images are acquired in a certain way to be able to look and make sure the surface of the camera is uniform across the sodium iodide crystal. And differential uniformity, not to go belabor the point, but the techs do this every day in terms of looking at along lines and along both horizontal and vertical lines, whether there's uniformity across certain pixel groups. And so this is an example of integral uniformity, the entire face of the camera head. And you can see the one on the top, there's about 5% non-uniformity. So that's not too bad, that's acceptable. But look at the bottom, that's like 12%. And look how patchy that camera face looks, okay? So this would be totally unacceptable, the bottom one, and you'd lead to a lot of artificial perfusion defects and everything else if you were to image a patient with this kind of camera. So when we do these kind of floods on a daily basis, we have to correct for any kind of non-uniformity there is in the crystal surface before we image patients. Okay, so we do two types of extrinsic, two types of uniformity corrections. One is intrinsic, and this is just basically imaging the sodium iodide crystal without the collimator. And we do also extrinsic measurements, which measure the quality of the collimator as well as all the electronics. So we do two types of different measurements to evaluate and to quality assure our instrumentation. There are many causes of non-uniformity. The crystal can get damaged. In the old days, if you have a PM tube system, the PM tube could fail. You can have improper coupling of the PM tube to the crystal. You can have incorrect application of the correction maps, because again, remember, we do correction maps every day on the information we get based on flood sources, and electronic failure is another source. Okay, spatial resolution and linearity are really not applicable to CZT cameras, but they are applicable to cameras that still use photomultiplier tubes. And that also needs to be corrected, because as light goes in and as electrical signals go out, they can vary, particularly in the center versus the periphery of the PM tube. And that can cause a problem with spatial recognition of an object. To look at that, we do these things called bar phantoms, which are basically just parallel lines at different widths to be able to see whether we have adequate spatial resolution on our systems. And lastly, we do center of rotation, and center of rotation is really not applicable to most CZT cameras. There is some type of center of rotation that is done with CZT, but it isn't the traditional type, because traditional gamma cameras rotate around 180 degrees, and that rotation has got to be precise, otherwise you get distortion of the image. With CZT cameras, it's a fixed gantry, so you don't really have to correct for rotation errors because it's non-rotating, but you have to correct for other things. So this is what happens if you have center of rotation errors, and you can see that on the left, this is with a 1.5 pixel difference. You can see there's a apical septal perfusion defect, and I'm sure that's okay. You can see an apical septal defect. If you look at the middle panel, which has no pixel deviation, you can see that looks really good. And if you look at the right, that's a 1.5 pixel deviation. You can see you have an apical lateral defect. So, if your center of rotation is not accurate, you can clearly develop false positive perfusion abnormalities, and that's one of the reasons why we do these corrections on a routine basis. Okay. So let's talk a little bit about artifacts, and we have motion artifacts, which can be vertical, okay? They can be horizontal. You can have bad distribution of tracer. You can have inadequate tracer distribution because of infiltration of a dose. You can have extra cardiac interference. You can have areas that have abnormal uptake or contamination, such as with gut uptake, etc. And you can have attenuation patterns from breast and other soft tissue problems. So this is motion artifact, and you'll see on the top there's an anterior defect, and on the bottom software was used to motion correct, and you can see that defect goes away. Okay. Now, let me tell you that we don't usually like to use software, because software can sometimes make things look worse than they actually look to begin with. So the best type of motion correction is no patient motion, period. Okay? And that goes for many different technologies, not only SPECT and PET, but also CT. We hate patient motion. It causes a lot of angst and frustration. And a lot of times, motion correction algorithms really don't work. This is an example of x-axis motion, and you'll notice that the lateral wall has a defect on the upper panel, and on the panel below, the patient was re-imaged, and now that abnormality is gone. Okay, so with SPECT imaging, we can actually look at the raw data, and we can see if there's up and down motion, or we can see if there's lateral motion, and if there is, either it needs to be corrected, and if it can't be corrected on the spot based on algorithms, then the patient needs to be re-imaged. Otherwise, you run into these problems. Incidentally, PET is no different than SPECT. Now, PET imaging is a little bit faster because the half-life of the radio tracer is only like 70 seconds. So patients don't need to actually stay still for as long. But believe it or not, people still move. And this was a recent patient of mine, actually, who had a PET scan. He had a normal PET scan 3 years ago, I guess. And then he had another one just for surveillance of coronary disease and had this anterior defect shown by the arrows and this infraapical defect. And it was called LAD ischemia because the bottom images look normal, but on the bottom images there was no motion. And in fact, if you look at this particular, you can see that on the stress images up the top panel, the patient is just going like this, okay? So this was I hate to say, a misinterpretation based on a poor set of images. And the patient really should have been re-imaged to begin with because then he had a CT and he only had mild disease. You really do need to be cognizant of when you look at these images in terms of how they were acquired and what the raw data looks like before you make any kind of interpretation on these patients. Okay, another issue is breast attenuation. This can also be seen in male patients. It's not just female patients. And part of the problem with breast attenuation is also differential breast attenuation. So for instance, on the left-hand side, on the top panel, you can see a defect in the anterior wall on the stress images, but on the rest images, there's no defect. And that's because if you look on the right-hand panel, you can see on the stress images, the breast was only partially covering the heart. And on the rest images, the breast was completely covering the heart. So there was uniform attenuation, okay? And this patient was said to have, LAD ischemia, okay? Well, no, it was just differential breast attenuation. And again, sometimes we can get away with this because now we do prone imaging and we also do CT correction. But, this is something also to be aware of. This is another patient, same kind of thing. This was about 10 years ago. A patient came through the ED with the scan up on top, she was 90 years old, incidentally, and she had this anterior defect. And on the rest images, she had none. And you can see she has about a 15% ischemic defect on the polar maps. And, this patient had normal ejection fraction. And despite her age, she had completely normal coronary arteries. And it was just breast attenuation, again, differential breast attenuation between the two scans, stress and rest. Diaphragmatic attenuation is more common, and we see that all the time, especially in males, although it can happen in females as well. It usually looks as an inferior defect, and this is an example here. You can see on this image that you've got a decrease in counts in the inferior and posterior walls. We can hopefully correct for this. We do prone imaging quite frequently. This is a patient, you can see, he's got an inferior defect. On regular supine imaging and on prone imaging, it goes away. And when perfusion defects go away, they're artifacts. Or if they change position, they're artifacts. True defects don't change with position, okay? So that's one of the reasons why prone imaging is so powerful, because even an anterior defect, if you have an anterior defect on one set of images and you have a lateral defect on the next set, but the anterior defect goes away, it's all artifact. It's differential breast positioning or whatever, okay? Of course, we also try to do CT correction on all these patients. Not all SPECT cameras have CT correction, but some do, and whereas with PET, it's universal, okay, for CT correction. But it's coming to that point also with SPECT imaging, and especially with CZT SPECT cameras. And you can see on this patient, this patient had quite a bit of diaphragmatic attenuation, which again, you should always be looking at the raw data to be able to see. And incidentally, his ejection fraction was totally normal, which should also be a little bit of a heads up about the fact this is probably artifact when you see thickening of a wall like you do here. Okay, the other thing is you can have adjacent subdiaphragmatic attenuation, count activity, like from liver and stomach and bowel. We see a lot of that bowel stuff, stomach stuff more with PET imaging. We see liver and bowel with SPECT imaging. And the problem with subdiaphragmatic count activity is that it can either contribute counts to the myocardial wall and therefore hide a defect, or it can overlay a wall so you can't read it at all, or it can create what we call a ramp filter artifact and actually induce a defect that really isn't even there. So subdiaphragmatic count activity is a real problem in SPECT imaging, and it's really kind of a difficult thing to get around. But one way we can do this, here's an example of a patient. This is what we call a ramp filter artifact. And you can see there's an inferolateral perfusion defect, and that inferolateral perfusion defect is due to the high subdiaphragmatic count activity using this particular ramp filter. And you'll look at the bottom one, and this is now using iterative reconstruction, and that completely goes away. So when we have people who have artifacts, particularly with ramp filters, we can do one of two things. We can either re-image the patient after giving them water or whatever to try to get rid of the gut activity, or we can use iterative reconstruction to help us. Finally, I'd like to talk a little bit about tracers. Tracers are very important. This is looking at myocardial tracer uptake versus myocardial blood flow. You can see that O15 water is actually the only one that's linear. You can see that some of the SPECT tracers like thallium and technetium agents really have a lot of rollover at high flows, okay? And incidentally, rubidium also is no better than technetium, either technetium sestimibia or technetium tetraphosphate in terms of rollover at high flows. And that rollover at high flows can actually reduce or eliminate a perfusion defect. So here's an example. This is looking at O15 water, F18 fluoropyridaz, which actually has uptake similar to O15 water. It's almost linear, unlike the other ones. Then you see ammonia and rubidium, which has the worst uptake at high flows. And you can see that in this particular patient, based on O15 water changes from stress to rest, this patient would have had a 25% perfusion defect. You can see because of the change in flows between the two studies. But if you looked at this on a rubidium scan, that patient would only have a 10% defect because the flows on the normal area are not much different than the flows on the rest. So the stress and the rest don't look much different, okay? So it's really important that we, have tracers that, at least within the realm of what typical flows are for us during stress, that mimic accurately what flow should be, rather than having rollover effects where a tracer is not picked up appropriately according to the flow that the myocardium may be seeing. And of course, as you know or may not know, there's actually been now data published comparing fluoropyridaz to technetium, which has actually shown better sensitivity, which is not surprising in terms of detection of coronary artery disease. Really no better detection in terms of specificity, but in terms of the ROC curves, all things, particularly in women and obese patients, improved with fluoropyridaz as compared to technetium. And image quality was better, and accuracy was better, and radiation dose was less. And what's also interesting about this study is when they compared perfusion defect sizes, the defect sizes on a fluoropyridaz study were significantly larger than the defect sizes on a technetium study, which again has to do with more, or I should say less rollover on the fluoropyridaz, with the fluoropyridaz radiotracer as compared to technetium 99M. So overall, we're getting into the realm of better tracers, and nowadays I would really recommend, on your PET studies, you have the option of getting fluoropyridaz studies. I would definitely go with fluoropyridaz rather than rubidium, if possible, because it does have better diagnostic characteristics as compared to rubidium, and certainly better than technetium. So I'm going to end on those thoughts. We went through a lot of information. I really didn't talk about stressors. That will come next. And of course, there's the whole issue of clinical application for all of these different tests that we do, which is a whole nother story. Thank you very much.